Hello and welcome to DM2 Essentials, Understanding, Managing, and Thriving with Myotonic Dystrophy Type 2. Today's session will run about 1 hour. My name is Annalise, and I have been an intern with the Myotonic Dystrophy Foundation. Dr. Johanna Hamel studied medicine in Germany, completed residency and fellowship training at the University of Rochester. Her focus and interests are neuromuscular medicine and DM. As a clinical researcher, Dr. Hamel focuses on natural history studies, disease progression, biomarkers, and transcriptomic changes. She is a co-PI of the Wellstone Muscular Dystrophy Specialized Research Center. In the clinic, she cares for DM patients. Dr. Hamel focuses on remote patient assessments, methods, and patient registries. With MDF support, Johanna ultimately launched Reach DM. Dr. Hamel sees the developed methodology as foundational for expanded studies of genetic modifiers and the real-world impact of new drugs. Now, please give a warm welcome to our presenter, Dr. Johanna Hamel.
Thank you very much for inviting me to MDF, and thank you all for coming. And I'm very excited to be back at MDF with the DM2 community. The topic I was asked to talk about is really to give an overview and an introduction. A lot of the detailed topics will be covered by talks from my colleagues, and throughout the presentation, I will make references to those talks that I would like you to check out or check out the recordings. Okay, these are my disclosures. Just to start with some abbreviations, some people say MD for muscular dystrophy or DM, and DM2 can also be called by some primary care physicians diabetes mellitus. So it gets confusing. So just for us, myotonic dystrophy type 2, dystrophia myotonica, DM2, I will refer to this condition as DM2 throughout the talk. This is the outline, what we'll cover or try to cover. I would like to start with a diagnostic journey and give an overview over symptoms. The diagnostic journey in particular for people living with DM2, because it can be very long. And I recognize and appreciate that how long people sometimes live with symptoms before they have an answer. Then we'll go through the genetics, and that will get a little more complicated, but bear with me. And then we'll move on to symptoms of DM2 and how to best manage them at this point in time and how to build your team. So let's start with the diagnostic journey. But first, how many people live with DM2? Do we know? The answer is it depends on where you live on the globe. We don't know actually how many people live with DM2 in the US. It's really not known. We know how many people we see in the clinic, but that's probably a small fraction of people who actually have the disease. When you look elsewhere outside of the US, for example, in European countries, actually the other type of DM, DM1, that you'll hear a lot about, and DM2 have equal frequencies. So for example, in Germany and Finland, the frequency of having DM is actually similar for both diseases. So it's 1 in 2,200. And that just reflects a little bit on my history, because when I was training in Germany and I did a 4-month rotation for neurology and it was focused on neuromuscular, I, as a medical student, I was able to diagnose 3 people in 4 months with a new diagnosis of DM2. So it was very familiar to me then. And there is a higher frequency, it seems like. Now, illustrating that further, there was a study in Serbia, for example, where they looked at 150 people who had cataracts at a younger age than typical, so yet less than 55. And 7% of those folks had an unsuspected DM2 mutation. So they had a genetic test done and found out, oh, they have DM2. They didn't know about it. They didn't suspect it. But when they were evaluated, some of them had unrecognized signs of myotonic dystrophy type 2. And so bottom line, we think that in the US, as we don't know how many people actually live with the condition, it's probably misdiagnosed or underrecognized, because sometimes symptoms get attributed to other things like age-related changes or fibromyalgia or something else. Now, moving on to what are the first symptoms that most people experience? This is data from the National Registry that's housed in Rochester and has existed since 2000. So over 20 years, we have been able to ask patients in annual surveys how the disease is affecting them and what kind of symptoms they have and what was their first symptoms. So all of you who are members of the National Registry, thank you so much. This graph is edited from a paper that was published a while ago. And what you see here is on the y-axis, you see the symptoms that people report as being their first symptoms of DM2 looking back. And then on the x-axis, you see the percentage of people who experience that symptoms. And just to simplify it a little bit, so leg weakness is the number one symptom. That's the most common first symptom that people report, followed by general weakness, followed by myotonia, either in different body parts. It can be in the legs, in the ankles, in the hands or forearms. And then other symptoms that are reported are, for example, cramps or loss of balance. And here in the green bars, you see the diagnostic delay. Diagnostic delay means how long, essentially the time interval from first symptom to diagnosis. So how many years did someone live with these symptoms before the cause was identified? And so that is on average 12 years for people with DM2. That means the range is much longer. I have people in clinic that have had symptoms for over 20 years. And you see here in this registry data that, for example, if people experienced instability and balance as an early symptom, they weren't recognized as having DM2 most commonly. They lived with these symptoms for 22 years before it was recognized and properly diagnosed. And so for other symptoms, for example, myotonia in the legs, similarly, not capped, not recognized. It's a little bit different for when people experience cataracts that sometimes prompted the diagnosis a little earlier. But here you see that it depends on what kind of symptoms you had early on, if physicians picked it up or not. Talking about symptoms, and you just noticed on that long list that we just reviewed, DM2 can affect multiple body parts. And here is just a disclosure, because when I talk about DM2 and what it can do, just note that some of this may be applicable to you and some of it may not be. And that's because there's variability of the disease. And we don't understand it. That's what we're still studying. Why does the disease affect people different, even within one family? And so looking through the different systems, we call it a multisystemic disease, which means multiple body parts, multiple tissues can be affected. Now, the most conspicuous symptom that is shared by most people is the muscle weakness, and that affects what we call the proximal weakness. The proximal muscles are those that are closer to the trunk, like the legs here, the thighs, and the shoulder muscles. And the neck is actually a muscle that's weak quite early on in our studies. So when I see a patient in clinic and they come in with weakness in the legs, I always check the neck, because that's really early on weak in myotonic dystrophy type 2. And so it's not just skeletal muscle, smooth muscle can also be affected by DM2. So where is smooth muscle in the body? Almost the entire GI tract is made out of smooth muscle. So symptoms can occur from the mouth to the anal sphincter. Anywhere along that tract, there's smooth muscle. And it varies between people again, but it can include reflux, diarrhea, constipation, alternating or both, abdominal pain, gallstones. On average, people have their gallbladder taken out earlier compared to the general population. And then sphincter dysfunction. And then beyond the smooth muscle, the brain can be affected. Now, what symptoms can that include? Not limited to, but that includes increased sleep requirement, sometimes also excessive daytime sleepiness. But what I hear a lot from people is just they need 10 or 12 hours, and they sometimes they don't run into trouble because family members think you should get up in the morning, but it's just the natural requirement that they need 10 or 12 hours. And some of my patients actually need to modify their work schedule as much as possible to accommodate that, because their muscles feel better, their cognitive function is better if they get those numbers of hours of sleep. And then, of course, sleep apnea is another manifestation that we need to monitor. And we'll talk about all of this a little bit later, what to do about it, but I'm just reviewing kind of what systems can be involved when we think about myotonic dystrophy. And I would also say that yesterday someone said the neurologist is sometimes like the primary care physician for people with myotonic dystrophy. And that holds true in my experience. And it is a little easier when people live closer to me, then it's easier to coordinate and get things done. But it is true that it's hard to keep it all together, and someone has to hold the reins, because there are different pieces and different specialists that you will need to see. and someone needs to keep an overview. So talking about the heart, you think muscle disease, the heart muscle. Actually not, it's the conduction system, so the electrical wiring that's affected in myotonic dystrophy, so arrhythmias, conduction block, abnormal heart rhythm, and only in a small fraction of people there is a problem with the heart muscle, so heart failure. Moving on, we talked about smooth muscle. Smooth muscle is also in a lot of pelvic organs like the uterus. And we have more data on pregnancy and delivery and the sort of reproductive portion of women's health. For example, we know that people with DM2 have more frequent UTIs during pregnancy. We know that people have a higher risk for having miscarriages or ectopic pregnancies. And the rest of it, meaning there's more than that in women's health, like sexual function or menstrual function. Thanks to all of you who filled out our survey, we have a poster on that topic, including for patients with DM2, the data from the registry and the surveys. Lastly, hearing impairment, more common in DM2 early on. Yes, people who grow older do have more hearing impairment, but it's definitely DM2 related and more common and happens earlier on in life. The eyes can be affected with cataracts. There is an increased cancer risk. We'll talk about that, which means that we recommend age-appropriate cancer screening. Diabetes, I will highlight that a little later, an important one for DM2, higher risk of diabetes. And then sleep, we talked about the increased sleep requirement. And then there's a low IgG, immunoglobulin in DM2, which we are still trying to understand better what clinical implication that entails. And so this is a lot. And we will not go through it in every depth, but there are a lot of talks for DM2, and I've highlighted some of them here. So for example, there is a talk about the cognitive and the brain effects by my colleague, Dr. Pruvenant, Mind Matters. There is a talk on, or a session by my colleague in Rochester, Dr. Thornbrook, tomorrow on women's health. There is a talk on pain, and I apologize, but it happens to be at the same time as this talk, but there will be a recording. So please check out the recording on pain management in DM2. And there is a talk particularly for DM2 on genetic counseling. So I'm going to try to set the stage, and I know a lot of you know a lot about this already, so it will just be a refresher, and then to go into detail in those additional sessions. So let's move on with the difficult part, starting with the genetics of DM2, and this is familiar to you. And again, there is a genetic counseling session as well. But for those of you who are new to this, the condition DM2 is inherited in an autosomal dominant fashion. Autosomal dominant means that there's a 50-50 chance of passing on the disease to a child. And you will hear more about that, but essentially here is a mom and a dad or vice versa, and everyone carries 2 copies of a gene. And when there is a child, the child receives 1 copy of the gene from mom and 1 copy of the gene from dad. And for DM2, you have 1 abnormal copy of the gene. So 1 gene that has the mutation, the repeat expansion. And so you have 1 normal and 1 abnormal. And you have a 50-50 chance of passing on the abnormal one. And that risk is the same for each child. So if you have, with each child, it's like flipping a coin. So if you already have a child that may have DM2, for the next child, it would be the same risk, 50-50, no matter if there are already children that have been diagnosed with the disease. Now, looking at the genetics a little bit more, and why is this important? You will hear about therapeutics that are used for DM1, for example, and you will hear about therapeutics that may be in testing for DM2 in the future. And the important thing is to think about what are these therapies targeting and what are they tackling, and why can't we just take what works for DM1 and use it for DM2? But still, why some of the therapies might actually be transferable or adaptable. And so to get into that, I will give you a little bit of a background on the genetics and the mechanism to help you go through that and understand it or refresh your mind. So first of all, these 2 diseases are genetically distinct. So that means they're on the genes that are causing DM1 versus DM2 are on 2 different chromosomes, 2 different genes. And here you see that, for example, DM2 is on chromosome 3. And when we take a big microscope and we really focus in on that gene, so this is chromosome 3, and we look at the gene, which is CNBP, and we look even closer, what we will see is that on this gene, there's a repetitive code. It's CCTG, 4 letters. And it's a repetitive code. So it's CCTG, CCTG, CTG, and it goes on. And that's happening, that all of us have that repetitive code. Typically, or normal, is that you have less than 75 repetitions of this code, 75 times CCTG or less. If you have more than 75, that's diagnostic of genetic diagnosis of DM2. And on average, people with DM2 have about 5,000 repeats, so a lot more than 75. Now, why is this a problem to have this extra material on the DNA? This DNA gets transcribed into RNA, which then also is too long and has this repetitive code, which then is CCUG. Now, why is that a problem, just to have extra material there? This extra material kind of forms clumps. They clump together. And so here, this is an actual patient picture from a patient with a microscope. You see the muscle fiber in green, and then you see in blue the muscle nucleus. And then in purple, in the nucleus, these CCUG, these DM2 repeats, they just form clumps. And we call those toxic foci, toxic clumps. Now, why is this RNA toxic? I will explain why. This is the slide explaining why it is toxic. So here you see that the CCUG repeats, these RNA expansions, they clump together in this red clump. Now, what happens is, if they were just there, it wouldn't be a big problem. But the problem is that in these clumps, other proteins get stuck. Other proteins, RNA binding proteins. RNA binding proteins are important because they edit and splice RNAs from numerous other genes. And now they can't function anymore because they're trapped in here. So when we merge these two pictures, this is an RNA binding protein and then a DM2 fiber in a nucleus. So it gets trapped. So when you combine these pictures, that the RNA binding proteins are trapped here in those DM2 clumps. And why is this a problem? They're not doing their job anymore. And their job is to, for example, splice chloride channel RNA, so RNAs from different genes, and that causes myotonia. They don't properly splice and edit insulin receptor RNA anymore, and that causes diabetes. They don't properly splice and edit calcium channel RNA anymore, and that causes weakness, or sodium channel RNA, and that causes abnormal heart rhythm, and so on. And some of those channel problems, some of those RNA problems we haven't even discovered or understood yet, but this is really the problem in DM2, and we know a lot about it, not all of it. And why is this important? What could you think about? How can we rescue this or improve this situation? We can't just get rid of the CNBP RNA. We can't just take it away like we can in DM1, actually. We can't do that in DM2 because we think it's actually important to have some of that. So we can't just eliminate it. But could we do something, for example, to free those proteins or block them from binding to these toxic clumps? That might be a strategy that could be applicable to DM2. And that's actually a strategy that's currently being tested in DM1. So I'm hoping we're not too far out of testing some of those strategies for DM2 that we deem to be safe. And so we talked about how this is causing a multisystemic disease. You noticed your muscle weakness is in there, but diabetes and chloride channel issues causing myotonia. So really, that's the answer of why there are problems in different tissue types. Now, there is something, this is now a little bit going really more into depth, but I just want to share this because if you go to sessions, you hear a lot about the shared mechanism in DM1 and DM2, but there are some things that are really specific and special about DM2 that we need to think about when we try to do drug development. So for example, I mentioned these RNA binding proteins that are stuck in those toxic clumps. In DM2, actually, there is an additional RNA binding protein. You might hear a lot MBNL. That's one of those RNA binding protein that's stuck and can't function anymore. But there's also RB-FOX, and RB-FOX is particularly a problem in DM2 because they both bind to those toxic clumps. They both get stuck, but they compete with one another. And we haven't figured out entirely what that means. Is that good that they compete and push each other off, or can we modify this? Or anyway, that's something that happens in DM2 that we're learning more about. The other thing is the expansion. So this repeat expansion, the CCTG repeat expansion, is on a section in the gene that actually gets cut out usually. So usually when you have exons and you have introns, you might remember that from biology. So the introns are actually segments here you see in blue that get cut out in the process of RNA processing. And the exons are really important. That's where the information is on. So that there's information on the exons that determines the eye color and the hair color and how the protein should look like that makes up your body. So why is DM2 then a problem if it's on an intron, and why is it not cut out? It's more of a recent discovery that these expanded repeat cause it to be not cut out. So it gets included in the final RNA. And so that's another problem that we have to think about when we think about treatments for DM2, which isn't the case in DM1. And then just so that you've heard the term, there's another thing that ran translation, a more recent discovery that's also taking place in DM2 where abnormal proteins are formed. So now I think that was enough on genetics. It's just a simplified overview, but I think the bottom line should be we actually know quite a bit. We know a lot. We should know more, and we're still striving to know more. But knowing about all of this is incredibly important when we think about how can we develop targeted treatments that really tackle the root cause of the disease. Now let's move on to symptoms of DM2 and how to best manage them. I might make up a little bit of time here because I know you are the experts. You live with DM2 every day. And I learn a lot from patients in clinic. So I'll just review what we've learned in our studies and through you in clinic. But again, the pattern of weakness usually starts proximal and then can progress distally, which means it can move to other parts of the body, such as the ankles or the hands. Best what kind of problems arise, but climbing stairs and getting up from a chair and those things can be a challenge. What do we do about it? Meet with a physical therapist, meet with your neurologist or neuromuscular expert, evaluate how this is affecting you, what activities are limited, and then really ask about what can I do in terms of exercise and activity. And exercise is really, in my clinical anecdotal experience, incredibly important for people with DM2, but it's also challenging to find the right regimen that's tolerated. And then, of course, talk about assistive devices as they're needed. What's out there? What can I use? How can I make my life easier so that I can engage in the activities that are important to me? How can I get out of there in the community if I have mobility issues? So moving on here, exercise in DM2, again, just highlighting the sessions. There have been studies in the past showing that exercise in DM2 is safe, that people can increase their muscle, and that there are positive effects of exercise. That's out there in the literature, but there's ongoing research as well. And you will have a talk, there's a highlighting talk here as well at the conference. And then there's several sessions on exercise. Now, just one comment, because people are differently affected, there is no one fits all. You can't look up a paper and say, okay, this is what I'm going to do. It has to be tailored to your situation. And so meeting with a physical therapist and coming up with an individual plan is helpful. Now, we talked about assistive devices. Now, in clinic, I do have people ask me, what's my risk? Now, I have DM2. I was newly diagnosed. What is it going to look like in the future? And what is my risk, for example, to have to use a walker throughout my life? And so I can tell you that from the registry data, again, thanks to you who fill out the surveys and participate in the registry, people have reported to us that, I should orient you to this graph because you will see some of these graphs over and over. So the y-axis represents the probability for an event. So for example, the probability to use a walker. And the probability of 1 is everyone would use a walker. The probability of 0 is no one uses a walker. And that with age on the x-axis down here, so as people get older, the probability of needing a walker increases. And so the probability of needing a walker by the age of 50 is about 10% in DM2, and it's about 30% at age 60. And then it increases with older age, but be mindful, if we did a study in 80-year-olds in the general population, there would also be people using a walker for different other reasons. But it does increase as we go on. Wheelchair use, again, sometimes I get the question in clinic, what is my chance to need a wheelchair in my life? Again, the best we can tell at the moment with the data from the registry, which is 20 years of longitudinal data, is that the probability of using a wheelchair prior to age 60 is about 13% in DM2. And usually people don't need a wheelchair before age 40. Now, again, there are always exceptions, but that's the general impression. Now, I will move on. I know you skipped the pain talk to be here, and I feel a little bad about that, but I'll cover the pain a little bit. And again, you can listen to the recording from Dr. Gutman as well. But how common is pain in DM2? It's common. It varies, though, between studies. So some studies say 50% of people reported pain, others do 85%. I'll go through here a little bit quicker, but I just wanted to highlight it's actually quite common and it's a big problem. And it sometimes is the first symptom. And so, for example, one study here had 96% of people had pain. And you would say other people with issues with muscle diseases also have pain. And that's true. But it does seem to be specific. There seems to be something specific about DM2 because, for example, here is a study that compared the pain levels to other people with muscle diseases, and they had 75% of pain, while it was 96 in DM2. And so why is this of interest? It's of interest because we have to figure out how to improve the symptom, but also from a mechanistic standpoint, what is it that's causing pain in DM2? In the US, because I just highlighted some European studies, in the registry, for example, in a registry-based study, 80% of people with DM2 reported pain that was impacting their lives. So not just here an ache here and there, but really pain that is part of a life. And then what kind of pains are there? So people described it as an unpleasant muscular sensation, as stiffness, or difficulty initiating or controlling a movement. Where is the pain typically in DM2? A study compared the pain location in DM2 compared to fibromyalgia here in the middle, compared to healthy controls. And you see, essentially, the bottom line from this slide is the most affected muscles in DM2 are also the most painful ones in general. For example, the thighs here, oftentimes I hear this burning kind of sensation in the thighs. And then, of course, the shoulder muscles can be affected as well, compared to other pain syndromes that affect people very differently. So that there seems to be something specific that maybe something in the muscle, the splicing, we will have to figure it out, is causing the pain. The pain quality or the character is often described as dull, stabbing, tender, but there are many words for it. What improves or worsens the pain? That's a mixed bag too. It can be worse with palpation, for example, of the muscle. It can be worse with cold temperature. In about 50% of people reported that. It can actually be worse with exercise, which is a challenge because we tell you to exercise. And so I have learned from the patient community that it depends on what exercise. It depends on how fast you exercise. It depends on how many breaks you take in between, what type of exercise. And there are different plans for different people that work. And so it takes a little while to figure out what is actually the right exercise program. I can tell you, though, that I do have patients who say, I need to exercise. If I don't exercise with their specific program, I don't function. I have much more pain, et cetera, et cetera. So it can be really a crucial modification in people's lives to do that. So it takes time to figure that out. And I recognize that. And we need to do a little more research, which is being done to help you in that process. And then, so that's the bottom line about exercise. Now, how does pain impact people? I think it's intuitive, but still it's important to see that, yes, it impacts life quality. And here you see, for example, things about well-being on the y-axis, like social function, emotional well-being, energy levels, participating in social activities. If people have pain in the solid dark squares compared to no pain, which are the non-solid squares, they score closer here, which means less well-being in those aspects if they experience a significant amount of pain. So yes, pain is important, of course, and it seems to be specific DM2 pain. And now what is that specific DM2 pain? What's the root cause of this pain? There is a study out there that showed transcriptomic changes. So essentially gene expression, what genes are expressed in people's muscles that have pain versus in people's muscles that don't have pain. And the ones without pain are on the right side here. And these are a couple of genes here. And the ones with pain are on the left side. So obviously there is a difference how these genes are expressed. And so we need to do more research to figure out what is it on a molecular level that drives this pain and how can we tackle it. that goes to the next slide. And this is what Lori is talking about right now. And I hope you get to see the recording. How can you manage it in the absence of a targeted specific treatment that tackles these molecular changes that we think is causing the pain in DM2? Again, some of it we mentioned already. I typically say, try to characterize your pain, try to localize it, make a map, where's the pain, try to identify triggers. Are there any non-DM2 causes? We don't want to chalk up everything to DM2 and not pay attention to other things, because people with DM2 can have other medical problems too, and some of them might be modifiable or addressable. So if there's a bad knee, the bad knee still needs to be addressed. And then look at if I have people who do physical labor. And is that really a good thing at that point in their life? Is there any way that can be modified or accommodated that might worsen the pain? Or people sit all day in a chair doing a desk job. That might not be the right thing either. Then they don't have time to exercise and it might worsen the pain. So those are things to discuss with your provider. And then in terms of therapies, I'm not going to go through it too much, but one thing, statins. People with DM2 often don't tolerate statins. Just discuss with your provider, can I stop it and see, do I really have to take it? Yes. Can I stop it and see if my pain or my muscle function improves? And if so, then there are alternatives. There are statin alternatives that are more expensive, and you have to convince insurance companies to pay for them, but they are there. So don't just stop the statin. That's not what I recommend, because they can be very helpful for health, but consider alternatives because they can cause worsened symptoms. And then the one thing I wanted to mention here as well is consider treating myotonia. So if there is pain with transitions, if you have a lot of pain after sitting for a long time, after a long car ride, if you feel like I'm frozen when you stand up after sitting for a while and then it loosens up, I'm thinking there might be myotonia in the muscles. And it's not as easy as in DM1 where I have people just make a grip and there it goes. You can watch the myotonia very easily. In DM2, it's harder to tease that out because the myotonia is in these muscles and in those hip muscles. And it's hard for us to tease out, to look at it at the bedside. But if I hear that story, it might be a consideration to treat myotonia, particularly if it gets a lot worse in the cold temperature, which myotonia does, and if it's with transitions. And then there are treatments to improve myotonia, such as mexiletine or ranolazine. Just make sure you have an EKG first and it's safe for you to take those medications. And it's usually trial and error. You try it out. If you don't feel better, stop it. You don't want to add another medication to your list if it's not doing anything for you. But I do have patients with DM2 on these medications on occasion if it's the right match. Now we're moving on to the heart. Just in general, keep in mind, you may not have any symptoms. In fact, most people with myotonic dystrophy don't have cardiac symptoms, even if they have cardiac disease. So you may not have dizziness or palpitations or chest pain or passing out spells. If you do, definitely it's time to go to the emergency department or to your cardiologist or get care ASAP. But if you don't, you still need to see the cardiologist. You still need to have cardiac care. And believe it or not, but I had a patient in my clinic who was told by her cardiologist that her heart is fine and she no longer has to come back because it's fine. Not true. You have to go back every year because conduction abnormalities can develop, not in everyone, but again, they can develop throughout a lifetime. You also can have conduction abnormalities and heart disease, even if your muscles are still quite strong. So younger folks, when patients see me in clinic and they say, I have this niece or I have this other cousin family, they don't want to get tested. There's no treatment. What's the point? There is a point. We want to prevent bad complications, such as sudden cardiac death, which is less frequent in DM2 and more rare, but it has happened. There are case reports out there. And there's the simple thing you can do. You can get an EKG with your primary care physician every year or see a cardiologist. And so I always tell the families, if your family members don't want to get tested, just tell them to get cardiac care. That's the one thing I recommend. And yeah, and so the care guidelines say that if you have an abnormal EKG, you do need to see a cardiologist. If you're greater than 40 years of age, you need to see a cardiologist. And that includes an echocardiogram, an ECG, and a Holter monitor, usually at the minimum. So going down here, this is if you have heart disease, at times there needs to be a treatment for it, which is a pacemaker. And so when we ask people in the registry, did you have a pacemaker placed? The probability of having a pacemaker placed prior to age 60 in DM2 is about 10%. And I should have said that. I hope you saw that. But the dashed line, which is what I'm highlighting here, the dashed line is DM2. So it's about 10% in DM2 in the registry prior to age 60. Now, this just asks, did you have a pacemaker placed? This doesn't ask, should you have had a pacemaker placed? Did your cardiologist care properly for you? It's just really, the numbers may need to be higher depending on care availability. But that's the risk, the general risk. This matches other studies in the literature as well. Now let's move on to respiratory weakness and sleep disorders. I've bundled them here on this slide because they can cause the same issue, which is excessive daytime sleepiness, non-restorative sleep, waking up in the morning after 10 hours, yet feeling like you need another 10 and you're not fresh and energized for the day. So what could be the causes in DM2? If you get enough, some people come and say, I sleep 4 hours and I'm not restored. That's not enough hours. But if you do get enough hours and you're not restored, possible causes could be respiratory weakness, so the muscle that is generating the breaths at the diaphragm and the expiratory muscles. That we usually monitor those muscles in the clinic. It could also be that you have sleep apnea, or that, and even in the absence of those things, in the absence of sleep apnea or respiratory weakness, the effects of DM2 on the brain also can cause sleepiness. So what do we do to monitor for these symptoms? Pulmonary function testing, so spirometry, checking your breathing function, is recommended in the care guidelines every 2 years, definitely prior to surgeries. It needs to be done sitting and supine, because oftentimes you have to explain to your providers why things need to be done. And what you need to, it's important to do it sitting and lying down, because when you sit up, your diaphragm helps you breathe in, because the diaphragm moves down when you take a deep breath. Now, if you lie down, the gravity doesn't help anymore. It doesn't pull down the diaphragm. When you lie down, your muscle has to work harder because gravity no longer helps to push down the diaphragm with each breath in. And so oftentimes issues occur first at night, because your diaphragm works all the time at night and gets tired. And so what can we do to assess that? Because you look great in the clinic, well, we do it sitting and lying down. And if the breathing function drops down when you lie down, that's indicative that there might be an issue with that diaphragm muscle. Not as common in DM2, but something that closely needs to be monitored. And so the treatment is CPAP or BiPAP or non-invasive ventilation. Now, what is the risk in DM2? Here again, the dashed line is DM2. Here's the probability. So by age 50, 10% of people with DM2 reported that they needed CPAP or BiPAP. And by the age of 70, it went up to 28%. Again, that's an underestimate a little bit, because it's asked, are you using BiPAP? And there are people who should be using BiPAP, but they couldn't tolerate it. So whenever you have excessive daytime sleepiness, the things to do, or non-restorative sleep, or an increased sleep requirement, the things to do is get a breathing test and talk about a sleep study. Moving on to mood, energy, cognition. Again, I'm going to highlight here the talk by my colleague, Dr. Puvenant. So she will focus on this in particularly, but generally there is fatigue, depression. People experience at times problems with thinking, memory, planning, executive function, as we call it, or just a sense of fogginess. And I like to highlight then, just let's talk about sleep as well, because bad non-restorative sleep can have impact on cognition and mood. And so it's not just one thing we discuss. We have to discuss all of the above. And then what to do about it? Again, I mentioned address the sleep disorders and antidepressants, particularly if pain is playing a role as well. There are medications that can help, and of course, counseling. But really addressing all those different things, including physical therapy, getting the sleep addressed, is important when we tackle symptoms of depression and fatigue. And then, of course, I should have mentioned the socioeconomic factors, right? Are you still trying to maintain a full-time job? Is that maybe adding to the stress? Is there something we should discuss as a social worker consultation important, etc.? Accommodations at work. It's complex. Now, cataracts, eye disease, I'm going to go through that a little quicker, because see an ophthalmologist if needed. You need to have cataracts removed and cataract surgery. And they can come back, so don't stop seeing an ophthalmologist, even if you had surgery. Now, GI symptoms, I'll be a little quicker here because we started so late. But again, I mentioned earlier already, there's a lot that can be going on. Reflux is often a very common symptom. So, and particularly in the morning when you wake up after lying down, reflux can be an issue. And then liver function abnormalities can also be seen. So if someone noticed, oh, the liver test, the laboratory liver tests, transaminases are elevated, we need a liver biopsy. Then just say, hold on, DM2 causes elevated LFTs. Is that really outside? We should always check, is there something else going on? But to go something such invasive like a liver biopsy, we need to make sure it's not just obviously DM2. Sometimes it's helpful to consult with these GI specialists and alert them to this fact. And then at the moment, we don't have treatments that are targeting the root cause of DM2 in the smooth muscle, hopefully in the future. At the moment, the treatment is supportive, what usually would be prescribed for irritable bowel syndrome. Endocrine. I want to highlight something here. So the general symptoms can be diabetes, hypothyroidism, problems with fertility, or low IgG. So monitoring of blood work every year, like TSH, fasting glucose, or hemoglobin A1C, are important. But what I want to highlight here, because you've looked at these graphs now a couple times, and you got used to the fact that the solid line is on top of the dashed line. What's happening here? The dashed line is on top of the solid line. So the risk of developing diabetes is actually higher in DM2 than in DM1. And so the probability of developing diabetes prior to age 60 is about 24%. And that's important. And why is this? From a mechanistic question, that's very interesting to me. And I think we're studying this. Is it because the muscles that are insulin resistant are bigger in DM2 because they're proximal, the thigh muscles, for example? So we have to figure a little bit more out, why is there an increased risk for diabetes? And you have to just make sure your primary care physician keeps an eye on it and discusses dietary modifications or even medications if needed, something like metformin, if needed for diabetes care. Anesthesia, I will maybe rush through a little bit as well, but just be aware there is anesthesia guidelines on the MDF website. Most of you are probably familiar with them. You can download them or print them out. And what I recommend, print them out, take them to your anesthesiology appointment, take them to your primary care physician, take them anywhere you can, and provide your doctors with this information. And then if you have the impression that doctor isn't going to read it, that might be a discussion about to have. But most physicians are wonderful. And I've had phone calls with physicians who wanted to chat with me, and they had already read the guidance and so on. I think it's really great. You have a rare disease, so you will educate everyone else, including me. But just make sure you just provide the information, and then that's a good step to be safe. And luckily, the MDF has prepared these great resources, and they're available on the website. And just bottom line is, yes, there can be issues with breathing. There can be issues with being more sensitive to sedating medications and things like that. And it's all outlined on the guidelines. And then pregnancy, again, you're welcome to see our poster on this topic as well. But there are papers in the literature, there is information that people with DM2 have more frequent UTIs during pregnancy. Some experience some worsening of symptoms, and more miscarriages occur. Many people with DM2 have very successful pregnancies. So it's important not to get discouraged. It just means that it's good to speak to someone who knows about it, or alert your OB about this literature, about this information. And again, we'd have to study more. There isn't that much information in the literature about these issues in DM2, and particularly we know little to nothing about sexual function or menstrual function. And so we're doing research in that area. Now, cancer, the information, again, in cancer is somewhat limited, but it seems to be increased in DM2. And what is recommended is not to have you scan from head to toe or get too anxious about it. But what is recommended, make sure you are up to date with age-appropriate cancer screening. That means seeing a dermatologist for melanoma checks every year. Everyone should be doing this, but I'm just saying, I really prompt my patients with DM2 to just do it. And then see your OB for age-appropriate cancer screening. And then the one thing I throw in there that's not true for the general population is thyroid ultrasound every 3 years for thyroid cancer. Yep, that's it. And so when you look at it in the registry, when we ask people, did you have a diagnosis of cancer? What people reported back to us was that there is an increased risk, and the risk actually, the two lines are together. So there didn't seem to be a difference between the two diseases. And it increases with age, as it does for everyone in the general population. Increased risk for cancer goes up with age. And then the cancers, again, that I highlighted was melanoma, cancer of the uterus, like endometrium, thyroid, and others like colon cancer. And so lastly, and I'm not too much over, but how to build your team. I would just say, because I highlight the diagnostic delay at the beginning. And I'm a little bit passionate about that because, first of all, what a burden it can be to live with these symptoms for so long and not having an answer, or being told you made it up, or being told it's fibromyalgia or whatever it is. But there's also a risk to it, because if you don't have cardiac monitoring and you do develop heart block and you don't have symptoms, that's a risk. It's not appropriately managed. There's a risk of falls and not having the appropriate support. And then there's stigma, of course, right? Because if there's no medical explanation for muscle pain, this can cause difficult conversations with doctors. Or I sleep 12 hours and no one can explain why. That can cause issues even within families. And so having a diagnosis, knowing this is all related to myotonic dystrophy, having a unified answer to what's happening can be helpful, even in the absence of having a targeted treatment available yet. Not to mention anesthesia complications and not being able to counsel your doctors appropriately because you don't know. Now, I want to highlight here family planning. Just go to that genetic counselor session. Very important as well. Particularly just mention it to family members who say, I don't want to get tested because there's nothing there anyway. The two things I say, cardiac and family planning, those are things to think about when you don't want to seek care. And then socioeconomic disadvantage. There are people with DM2 who do require disability due to DM. And so the probability of going on disability due to DM prior to age 40 was 10% in DM2. So it's not zero. And even though the disease occurs later in life, we are probably expected to work even longer in life. So you might not be able to work as long. So having a diagnosis and having doctors support you in that process, what is a good work regimen for you, is important. And then I just want to highlight also Dr. Swanson's talk, a discussion about the future of DM2 research and therapeutic development, because we're doing a lot of work on that front. And to keep that in mind. Aspects of care, I'm going to go through that fairly quickly, but we captured all of them. The one point I wanted to make at the end is, just be mindful that not everything is DM2. So if you have neck pain, shooting pains into your arm, numbness, tingling, just make sure your doctors work it up like you didn't have DM2, because you can have other things too, and some of those can be addressed. So we don't want to just be blind to anything else. And because it's a multisystemic disease, it does take a little bit of teasing out what's what. But it can be easy to just push it all to DM2 and be done. No, we do still have to do a thorough evaluation and workup. And then establish priorities with your doctor. What do I want to talk about? What's my number one? What's my most bothersome symptoms related to DM2? 1, 2, 3. Maybe you have just one. Depending what it is, that's what I want to talk about today. Things like that can help guide the conversation. And with that, I want to close and open up the Q&A session. And of course, you're welcome to stump the DM2 doctor later too. Any questions? Thank you. First of all, thank you for your attention. I really appreciate it.
Does anyone have any questions? You can just raise your hand and I will come with the mic.
So you had a slide there's a slide, about lean muscle mass, and that it looks like you can increase your lean muscle mass if you have DM2. And so my question is, if you can increase your lean muscle mass, can that help delay some of the symptoms or improve some of the symptoms, like difficulty getting up off the floor? Can you actually improve your condition?
Yeah, that's a good question. So the picture or the slide that I had, so there's two things. One slide showed where the pain is. That was not a scan or anything. That was just patient drawing in where their pain is. And then the other slide is for the exercise. So that was a study that was done, and they exercised a small number of people with DM2, and they were able to gain muscle mass. And so in general, for both types of DM, we know that first, exercise is safe, because sometimes it's not when you have other types of muscular dystrophy. But so, by the way, I hope we're past that time, but sometimes people go to their doctor and they're told, oh, don't exercise. You have a muscle disease. Don't destroy your muscle. That's not true for DM. And so, yes, you can build muscle with exercise. It has to be gradual and targeted, and never start something quickly without being ready for it. Now, yes, you can build muscle. You may not be, it depends. You may also just be able to keep what you have and avoid muscle loss with exercise. That's what, now, in terms of beyond exercise, is there something else that increases muscle mass that you can take? I do get, the answer is generally no. Eat a protein-rich diet, eat healthy. People ask about steroids, muscle builders, bodybuilding type things. I can't recommend that. It's not been tested. And also, I would also be cautious because we're not all about muscle mass. We're about muscle function. So even if you build up your muscle, is it really going to get stronger? Or what does it do long term? Those are considerations. If you do have low testosterone, then you need to be supplemented based on medical indications. But if it's normal, at the moment, we can't recommend that. There's no evidence to support that. Yeah.
I believe there was a question in the front.
So one of the slides was about mobility aids. And I was just curious, was the distinction for kind of overall dependence on a walker and wheelchair, or is it just like occasional use for certain things?
Great question. And I could go back in, but I'm also, anyway, but I think you saw when we did, so great question. When we asked about wheelchair use, for example, the slide I showed, this is when people really use wheelchair more frequently, when it's part of their lives, not when you're at the airport and you take a wheelchair, or you go to Disney and you take a wheelchair, that, longer distances. That's not what is in that slide. It's really when people use it more frequently. We differentiated. And then the registry, people asked the question in different ways. Do you use the wheelchair frequently? Do you use it rarely for longer distances? So we looked at the data for longer distances. Now, the cane and the walker questions, the cane I didn't show, but the walker is really when they use a walker regularly. Yeah. That's the risk data I showed is for using it regularly. Yeah.
Is there an increased risk of elevated alpha-lipoprotein level in the blood? And also, are steroids safe for people with DM2?
What question, clarification, what protein levels?
Alpha-lipoprotein.
Alpha-lipoprotein. I don't know about that one.
Like whole cholesterol.
Oh, yes. Thank you for that. So cholesterol, yes. So we also recommend a lipid panel fasting every year because the cholesterol not just cholesterol, but the LDL, some of those lipids proteins are elevated in DM2, even though generally it's tested in the community and people can have hypercholesterolemia. But in DM2, it can be elevated even if you're fit and thin and you eat healthy. It's just the disease that causes it to be elevated. And so that goes back to the statin question. Yes, it needs to be checked, and it can be due to DM2, but it needs to be managed like anyone would be managed. So with cholesterol lowering medications, but again, then you can raise the conversation, should I use a statin or should I use something else instead? Because there are statin alternatives. And then to your second question.
Right. When I said steroids, I meant
statins. Okay.
Yeah. So statins can be recommended.
So what I usually say about the statins, because it's really the first to go to for high cholesterol or hyperlipidemia, what you're referring to. There are statins that are less well tolerated, and there are statins that are better tolerated. And so what I recommend is try the ones that are better tolerated. And so those are, for example, rosuvastatin or Crestor. And you can take it, for example, at a lower dose every other day and see if you feel any different. And if you feel like my pain is worse, my function is worse, my muscle strength is worse, then you have a conversation with your doctor and say, I failed the statin, it doesn't work. Can I have Repatha, for example, which is the statin alternative? The one that is less well tolerated in my experience is, for example, that's what everyone goes to, which is the Lipitor or atorvastatin. Specifically at high dosages, people can feel quite a bit off on that. Not everybody, but some. Yeah.
So my cardiologist wound up putting me right on initially Praluent, now I'm on Repatha. So
you are on Repatha. Okay. So I guess you're past the statin. So that's good. Yeah.
But they didn't even go there because they said that it wasn't good because of the muscle.
Yeah.
It
Yeah.
can provide additional muscle pain and weakness.
Yep. And if I have someone who has a lot of the pain, for example, because not everyone has a lot of pain, there are people who have little pain, particularly then you might want to go straight to the Repatha. But sometimes there are insurance issues, things that are outside of our hands. So then we start a little bit of Crestor and see if it works. But if it doesn't manage it properly, you also have to recheck your blood levels and make sure it actually works. Because if it doesn't work, then you go straight to Repatha. And if people ask me, if cardiologists ask me, what would you prefer? I would go straight to the non-statin alternatives if possible. Yeah.
Thank you.
Yeah. Yeah.
If you have a loop recorder, do you still recommend an ECG?
No, so the loop recorder is great. That provides, so I'm not a cardiologist, so that's
Right.
my disclaimer here. But yes, that monitors continuously your heart rhythm. And unless you have a heart attack or something, which you don't have, but I'm just saying that there are things that you might need an EKG for. But for recording, for arrhythmia, for myotonic dystrophy type 2, the loop recorder should give you the answer, as far as I know. Yes. So that's a step up for monitoring. Questions?
Thank you so much, Dr. Hamel. That was a wonderful presentation.